This is a difficult time. And historically, now is when wellness programs got cut. Why? Because they had not shown their value. And value comes from data, but it also comes from integrating into the management strategy so the senior leaders understand the value. So it's really important. Just think, when we're having fewer people, ESD is getting more employees, but for most of us, we're really getting fewer. And the workload is not going down. If anything, it's going up. So fewer people to do more work. So is that the time to really back off from having people get healthier? No, it's the time to put more effort in it. Usually what happens is when there's more money, more people, and not more work, is when wellness programs get funded. It's really backwards. So we have to really focus on that piece. And I don't see in the near future that the state's going to have more employees and less work. I think it's going to be fewer employees and more work. This is the time when wellness really has its biggest impact. So be thinking, how do we integrate it into management strategy? How do we say this impacts productivity? With that in mind, data-driven is really one of the ways to go. And here's your data. And I wanted to give, under cohort number 2, there's a couple of talking points. Everybody have that? Find it?
It's the thicker packet.
It's the thicker packet, and it's the first page called Observations. So a line that's not on there, and that was on the ESD presentation, awareness of employee health risks. This is something that did not exist. It does not exist for most senior leaders, but it does exist within your agencies. So awareness of employee health risks. So some observations. Cohort 1 and Cohort 2, working from the HWI data, which is all of your data together, is that Cohort 1 and Cohort 2 look like the first group brought their friends. They are the same. We didn't know if that was going to be true. We thought maybe the first people to show up were different than the second people. But now, with about 28%, a little over 28% in the first round, a little over 10% of this round, we're just about 40% of the total population. And from that, you can say that may be representative of the other 60%. But at least we know about that 40%. And in that 40%, there exists a high level of risk. And within that risk, there exists a high level of unidentified risk. So, as we've said a couple times today, rich benefit package. Everybody could go to their doctor on their annual preventive care visit, get all these tests done and pay little to nothing. But yet, look how many people didn't know. Some because they really seemed to be healthy. Some because they really thought they weren't healthy and didn't want to know. Some because they just didn't have the time. Some because their wife was telling them to and they weren't about to. So there's all kinds of reasons that people didn't know. But what we know is they didn't. But what we also know is that by offering this at the workplace, a lot of people showed up. Interestingly, we're at 40%. And statistically, nationwide, when you offer this, you get around 40%. Which is almost always higher than the number that complete their HRAs without incentives. Why is it? My opinion, it's because this matters a little more to people. People really don't get why the HRA is important to them, so they don't do it. But when the on-site biometrics, people show up at about 40% of the population. We saw a disproportionate female response. There were more. And it was about the same in both times through. We saw different risk patterns for male and female. One of the myths or widely held beliefs, and I hear it a lot at the Healthcare Authority as we're doing planning on how we're going to change health plan benefits. In fact, I want to tell you that this data is really being looked at as PEBB is going through a redesign and saying, what do we need to go from okay, because we have a rich set of benefits, and our cost stuff has been okay. We don't know much about the health across the population because we haven't collected the data. We're saying, how can we really go to good? And this data, the work that you're doing, is really informing that process for the benefits. So we really think that these on-site biometrics will become a part of the normal offerings in the future, embedded in the health plans, paid for by the health plans, but administered at the agency with agency level data. So that has good acceptance right now. But one of the myths, one of the things that I've heard often in these meetings is that by presenting data to people, such as here's your HRA, here's your risks, here's your biometrics, here's your numbers, here's your risks, that people go, oh, well, I'll go change. So Ned said, oh, I'll go change. Well, that's not the common response. The common response is, whoa, nothing happens. So you'll see some people that make a change, but across the population you see very little change. The data says HRAs result in almost no change across the population. Biometrics will be the same, unless you take the second step and you provide a supportive environment, which a work environment can be, and you provide behavior change tools, tracking tools across the population, and then you begin to see change. And we'll have the data from the CTIL program Sarah Eve will present, which was really a small little intervention program, but there were changes. Now, as you look at your data, I think what you're going to see is there are not a lot of changes. When you see cohort 1, the people that showed up in the first round and showed up again, so we have 2 data points, you'll see very little change. Would you expect change? Well, you always think there might be, but very seldom is there change unless you have a well-targeted, sustainable program. We were talking earlier, Betty Wilby and I, about being ready to change. And that when people get data about themselves and it would be good to make a change, many of us are just not ready. It's not the right time. Not good or bad, it's just not the right time. So what does an agency need if they're going to have change in these population numbers? They need a sustainable program so that when the person's ready, the behavior change tool is there. So Changes That Last a Lifetime is an example of one kind of program. And a lot of people chose not to participate. It wasn't the right time for them. But they saw some people succeed. They have some change in their work environment. And if something like that is offered again, you'll have people who weren't ready the first time say, I really want to do that. And they'll make change. And you know what they'll also do? They'll be supporting the people that made the change in the first one that need to be supported in keeping the changes. So you begin to change the culture. So it takes sustainability and through time. So as you look at your data, what I think you'll find is there's not a lot of changes. But what you have is data that says, here's where we need to look. And remember, this project operates on 2 levels. One, at the agency level, changing your agency and assisting your coworkers. And secondly, developing the process necessary so that we can change all agencies and that we can impact that partnership. That integration needs to occur between action at the agency level and the health plans. The health plans need to change, the agencies need to change, we need to do it together. So we're doing this work together.